pandemic is still affecting almost entire world. But in some regions, some countries, there are initials that situation is going to stabilize, and authorities took decision to start reopening. However, this reopening brings new challenges, concerns, and potential problems. Our next two speakers have both been working on the front lines of the COVID-19 response since January this year, and worked together during the repatriation mission for the US citizens from Wuhan to Nebraska for quarantine and isolation for COVID. So let me present Commander Michael Garner. Michael is working in the US Department of Health and Human Services, Office of the Assistant Secretary for the Preparedness and Response, and Mr. Dosefels, who is serving as a program manager for the University of Nebraska Medical Center, Region 7, Disaster Health Response, and plays an integral role in helping to coordinate the state's response to COVID-19. Gentlemen, nice to have you. So the voice is coming over the ocean. It's to you.
Hi, good morning. Can you all hear me?
Yes, we can, loud and clear.
Very good. The last time I asked. Hey, good morning, everyone, and good afternoon for there on your side. Again, my name is Commander Michael Garner. And first, I'd like to say I hope you and your families are staying healthy. That's a difficult thing to do in this current time. And I know it's a little sentimental, but I don't know if you can see this, but I'd like to share my coffee mug this morning. It's one of my trinkets from Disney World. It's a small world representation. And I share that with you because I do think that we truly are in a small world here, and we are in this fight together. And what I've heard from the previous conference speakers, like Mr. David and others, and the Colonel, is that we are hearing a common message of international cooperation. And so I think that's very, very applicable. So I'm going to go ahead and start sharing my slides, and I'll do a quick introduction of myself and Mr. Feltz, and then we will move forward. Okay, can everyone see my slides okay?
Yes, we can.
Very good. All right, good morning again and afternoon. My name is Commander Mike Garner. I represent the United States Department of Health and Human Services, the Assistant Secretary for Preparedness and Response. I'm currently serving as a Regional Emergency Coordinator for Region 7, which is in the Midwest of the United States, and I am located in Kansas City, just south of Kansas City in Overland Park, Kansas. My co-presenter is Mr. Dosefels. He's the Director of Operations for the Global Center for Health Security in Nebraska, in Omaha, Nebraska. Mr. Feltz and I have worked very closely together, as the Colonel mentioned, up in Nebraska earlier in the year on the mission for repatriation of the U.S. citizens from Wuhan, China to Nebraska, to the United States, early on in the grasp of this virus. And so it's very good to be working again with Mr. Feltz, and I look forward to hearing his words here in a few moments. So quickly, I'll just do a quick outline here. I'm going to give a quick overview. Mr. Feltz is going to talk through some of the initial episodes of outbreaks and resurgence, as well as talking through some vulnerable locations and hotspots and outbreak hotspots that we're seeing. I will speak briefly to some intervention tools that we have seen that are working here, and those to combat medical surge capacity. And that is around the concept of alternate care sites. And then I'll speak briefly about testing and contact tracing, and then give a summary and some additional resources. So quickly, here what we're seeing here in the United States is that positive cases are decreasing, which is a great thing. Our hospital visits are for COVID-like symptoms are declining. It's been nearly 2 months since, more than 2 months now, since the first stay-at-home orders were issued here in the United States amid the coronavirus pandemic. It's ravaged this country with more than 1.2 million known cases, and of course these numbers fluctuate, daily, with more than 80,000 deaths here in the United States. And so now I think this morning, I think we're more than 84,000 deaths. So nearly 2 months since the social distancing measures began, more than 35 states have begun to reopen their economies. And social distancing, which is something that Mr. Feltz will speak to, continues to be an important part of that reopening. Another aspect of reopening is the resurgence of hotspots and vulnerable populations, which continue to be a concern for us here. And indeed, the response and mitigation tools will continue to be an important aspect in reopening strategies. So with that said, what I'm going to do is I'm going to turn this over to Mr. Feltz. I'm going to discontinue sharing. I'll let him bring up his slides. He'll go through his, and then we'll pitch it back over to me.
Hello, everyone, and thank you, Commander Garner, for that very kind introduction. I do miss our time working together here as we were going through the repatriation efforts of those individuals from Wuhan, China. It was probably one of the most rewarding missions of my entire career thus far. And thank you to the crisis management and disaster response team for allowing me the opportunity to come here and speak to you, to this group of individuals today. I appreciate the opportunity. Sorry, I think I've got the wrong, there we go. Hopefully you're seeing the full screen and not the presenter view now. Yeah, but I appreciate the opportunity to come talk to you. A little bit of what we do every day here in the Global Center centers around looking at what's going on through the entire world, even though a lot of our operations are focused around what's going on in Nebraska and within our central region. So you kind of see some common trends and themes, looking at the data every day that is reporting throughout the country through the WHO's websites and through the Johns Hopkins websites. But you're also noticing some of the different challenges that countries are going through as they transition from a non-quarantine to quarantine, or excuse me, to social distancing type setting. And then now as we're trying to figure out how do we come out of that social distancing mindset. I found it interesting, the WHO has, number one, determined that the term physical distancing is more appropriate than social distancing. Social distancing being the idea that we are emotionally disconnecting from everybody, whereas what we're actually doing is just physically separating ourselves from other people within the population. So I learned that during doing some of this research for this presentation. And I think it's an interesting distinction as we move forward from here, because it's really the physical proximity to other people that is going to end up determining how successful different countries are as they go through this. So I pulled the WHO's criteria. I thought that was a good starting place. As you look through the world and how different countries are approaching physical distancing and then relaxing those standards, we're seeing some common themes, and they're kind of outlined here in what the WHO has. Every country has a different opinion of how they implemented these physical distancing rules, but also how they're relaxing them and in what order. And we'll come back to this. The one specific thing I do want to point out is down here at the bottom. This is definitely what we see in the current events that are going on in the world. Every country is different, but it even gets down to every community is different. And even depending on some of our larger cities, its subsections of those cities are different in how the pandemic is affecting their populations and their communities. So what I did is I started by looking through some of the data that's out there. I'm a numbers guy by trade, and so I always like looking at numbers and being able to compare apples to apples. So I came up with two rates that I think are representative of the impact that the pandemic is having on different countries. The first is our cumulative community attack rate. So, like your normal attack rate, this is just our infected population divided by our total population. That's going to give us a number. Because we're in the middle of the pandemic, that number is going to continue to increase because it's cumulative, right? We're having total number of case counts. And so what we're seeing is, countries that are in the beginning of the outbreak is going to have a lower number just naturally because they have lower total cases than a country who's far along in their outbreak because they've had months of cases that are being reported. So that's one important distinction to keep in mind about this number. It'll continue to grow as our case counts throughout the world continue to grow. And in some cases, because it's based off case counts, it's definitely impacted by testing that different countries do. And as I go through some of the data, you'll see the countries that are testing less are going to look like they've got a lower community attack rate, where in reality, they've got underreported populations that are positive that are not factoring into that. But it's an important distinction as you look at all the numbers together as a whole. And then, of course, the unsymptomatic folks who are being untested in the population, what we're seeing is countries that are testing a lot of people and identifying asymptomatic cases that are not being reported in countries that are limiting testing to just the symptomatic populations are actually, those countries are underreporting what they have because they're not getting that population. The other number I looked at was the case fatality rate, the total deaths divided by the total number of cases. The one thing to keep in mind about this number is if you're underreporting the total number of cases, it makes your case fatality rate a whole lot higher than it really is. And so because of that, it's a little bit challenging sometimes to compare one country to another based off of what their testing protocols are as a whole for the community. So what I wanted to start doing was look at globally, and I think some of our Asian countries were the best place to start looking because those were the first places that we started seeing massive outbreaks, but they're also going to be some of the first countries that we've seen those back-end relaxing of standards, and they're going through that process. And as a world, we're gonna learn from the things that they implement and the impact it has on their community as far as flattening the curve and reducing the impact on our communities. I just picked 3 based off of some of the news that's out there about these. I realize that the references that I have here are based off news articles, but in lack of perfect data out there for us to be able to examine scientifically, I think just those anecdotal news articles are a good way for us to see some of the things that are happening within our communities. A little bit of information about the graph on the right and some of the data that's listed. The graphs come from the WHO's website. You can actually go in there and click on it by country, and it'll give you the individual numbers for each of the countries. And then on the left, I've got some of the tests per million listed there, and that comes from Worldometers. And I've got both of those links down in the bottom right if you'd like to go look at specific data for your country or for a specific country. So the first country I pulled out was Japan. You can see when they started, and I thought their situation was interesting because they really were kind of slow to take a immediate action toward it. You can see their first case being in January, but they didn't declare a state of emergency until about April 7th. Their case counts and everything look about normal. Their community attack rate looks pretty low. But again, this is where the testing comes into it. All of a sudden, when you have a low testing rate, and you can see the testing rate of 2 of the other countries down there below, it's going to underrepresent what that community attack rate is because you're not getting the entire population added into it. And then their case fatality rate, we've got kind of a moderate rate there, but again, that's probably a little bit off just because we don't have a high number of people who are being tested and who are showing as positives. And so even though you have that low community attack rate, I think the interesting thing about Japan is they're struggling to keep their hospitals going and to get the support they need to be able to deal with the people in the community who need significant medical interventions. And I think that's why their numbers look like they're doing okay, but because they haven't been testing extensively, it's not a good comparison for other countries to look at when you look at just their total number of cases. So then I went on to Singapore, and the reason I pulled Singapore up is I thought they were interesting because they were doing very well in the beginning. You can see their tests on a per million basis. So they're testing a lot of folks. So even though their case counts are higher than, say, a Japan, it's because they're testing a lot of people. And so they're identifying those populations that are asymptomatic and not impacting your healthcare system, but they're still identifying those populations and being able to put mitigation methods in place that will allow them to prevent the outbreak from expanding significantly. The reason Singapore is interesting is they were doing very well at one point in time. And you can see right there, it looks like around the beginning of May, they all of a sudden started to see a spike in cases. And what that was is um, imported workers coming into the country, transient populations, who were staying in very close quarters dormitories. So as we continue through the presentation, we're going to talk about, alternate care facilities, and we're also going to talk about these hotspots, because that's what we're seeing most of the cases based off of, is we're seeing these one areas within a community that are high risk for cases, and then the next thing you know, you have an explosion of cases within your community based off of that one high risk population. It's not really a widespread the community like everybody's getting it, although it can lead to that, and that's where we see things like New York City and Italy, where they have those extremely high case counts because they have that initial outbreak in that core central area that expands throughout the rest of the community. So Singapore was a good case study for that. And then the last one I picked was the Republic of Korea. Again, you can see moderate testing there. They had very strict guidelines in place to control the outbreak when it first originally happened. Their physical distancing guidelines were kind of strict, and you can see it had an immediate impact on their total case counts. But what we saw here recently is, they released they eased up on their physical distancing standards, and then the next thing you know, one individual went to 3 different nightclubs one night, and they ended up with 40-something cases shortly thereafter. So it only really takes that one person who is, could have even been asymptomatic and didn't even know they were positive, but going to those very high density locations with high populations and actually spreading it to the rest of the community. So now as we transition over to our European impact, I kind of wanted to look at Europe because I believe that everything is down to the community base, but I also think our different countries have affected the ability to influence each other. So a regional view of things, I believe, is important as well. One thing to note down in the bottom right for Austria, I slid their graph over a little bit so their timeline matches up with everybody else. They didn't get their first case until almost a month after everybody else. And so the way the WHO's website reports it kind of made it look like they were going longer and it ended faster. So I just wanted to make it an even comparison with the other 2 countries that are listed there. So as we look at Italy, Italy is our case study for what happens when it outbreaks really quickly and we can't get a good handle on it and the healthcare system becomes overwhelmed. Because that's really the key to this whole thing is the individuals who need medical intervention being able to get the medical care they need so that they have a better ability to recover. But all of a sudden, when our health systems get overwhelmed, then they're no longer are able to treat the people who need medical intervention, and then our case fatality rates go up. And you can see that with Italy's numbers. Next, as we look at Germany, and I think Germany is a good baseline for everything. They had pretty good physical distancing measures listed. You can see they've got a pretty high test per million rate. Their community attack rate looks higher than some of the ones that we saw on the previous slide, but that's because they're testing a lot more people. And then their case fatality rate is kind of what we're expecting to see throughout the rest of the world, roughly around that 5%. And I think that as Germany starts to ease out of it, just looking at what that looks like, they're also pretty middle of the road standard with, here's the spectrum between extremely strict physical distancing rules and very liberal physical distancing rules. I think Austria, and I added them in because I think they're going to be a great view. They were one of the first countries that started reducing their physical distancing standards that were imposed by the government. And so if we imagine a 2-week lag or a 10-day lag, whatever the time is from the time somebody comes into contact with somebody who's positive and the time they start showing symptoms and become tested, I think we'll see that little bit of a lag. And so I think they're going to be one of our first indicators of what's it going to look like for countries to start reducing these standards and going back to life as normal. All right, so, I brought this back up, the WHO criteria, because this is what Commander Garner is going to start talking about here in a minute. The one I highlighted in the middle identifies that high-risk population that we're talking about. I don't necessarily mean like our elderly population being high risk of having detrimental medical effects. I'm talking high risk within the community where these are the settings that are going to cause those resurgence within a community and a high number of increased case counts based off of how we mitigate those risks. And Commander Gardner will go into that here in a minute. Some of the articles that I pulled out, just doing quick news searches and everything, these are the areas that we're seeing in the US and that I'm seeing throughout some of the other situations in the world. These are the locations that are going to have the highest potential to impact these standards as we start to ease them up throughout the course of the next month or two. Feel free to click on all the links. They should work and take you to where we're looking to go. So with that, I thank you for the time you've allotted me today, and I will turn it over to Commander Gardner. Hold on just a second, I'll unshare my screen. Oh, there we go.
Oh, great. Thank you, Dossie. That was an excellent discussion on the reopening and impacts. Really appreciate your words and wisdom on that. We're going to shift gears now and look at intervention tools. And I know we're running a little bit shy on time here, so I'll easily be able to finish this in 5 minutes. There won't be a problem. I'm going to go ahead and share my screen again. Okay, very good. So as Dossie mentioned, there's a concept that continues to serve its need post reopening, and that is what we're calling alternate care sites. When we first began seeing more and more of the cases of the virus and predicting that we'd have major impacts to hospital capacity, we asked ourselves the question, what would do the most amount of good, and what is our goal that we're trying to achieve? And really with the goal of alleviating that strain on the hospital system. And we came up with the fact that we need to get those asymptomatic and mildly symptomatic COVID patients out of those hospital critical ICU vent spaces. And so one way to do that is through moving those patients to these alternate care sites. We hear the term alternate care facilities, alternate care sites used interchangeably. I'll speak with it under the alternate care site terminology. So really it's a broad term for structures of opportunity. They provide a safe and comfortable setting where patients can isolate. They're located in hotels. They can be located in hotels, National Guard armories, so small military installations, community centers, dormitories, within close proximity to the hospital system. And here in the US, we've identified 3 types of models. We have a non-acute, hospital care, and acute care models for alternate care sites. The non-acute is general low-level care for mildly or moderately symptomatic. These patients may require oxygen, but don't require extensive nursing care or assistance with activities of daily living, or ADL. We have a hospital care model, which is a mid-level care for moderately symptomatic COVID-19 patients. These patients require oxygen, more than 2 liters a minute, and nursing care and assistance with ADL. We have an acute care model, which is higher acuity care for COVID-19 patients. These patients require significant ventilator support, including intensive monitoring on a ventilator. All these models, it's definitely not a one-size-fits-all. They've all been used here in the response and continue to be an asset post reopening, and they have resulted in hospital decompression and increased hospital surge capacity. So across the nation, we've seen alternate care sites set up in facilities like the Javits Convention Center in New York, where they've treated over 1,000 patients. And we've also seen smaller footprint facilities such as hotels that have been converted to healthcare facilities or care sites, serving an effective means of treatment and relief of that surge. And so what I'd like to speak to just briefly is the one that I had a big part in helping set up out in San Carlos, California. It was a Quality Inn hotel. It was with the goal of reducing unnecessary burden on hospitals and other healthcare facilities, help infected low acuity patients maintain isolation, and allow those low acuity patients to be monitored, treated, and quickly transferred if their condition deteriorated. We actually housed 61 COVID positive and PUIs there in that facility. We required no structural modification. That facility was leased by the state from the hotel owner. We had federal wraparound services provided, such as your laundry and your food service and your security. And then we had federal, and then pivoted later to a private medical 35-person team to handle the medical staffing for the facility. And so what we saw there was a successful decompression of the hospital system. And what I like to deem as Hotel California led to a blueprint for alternate care sites across the nation, and the development of an alternate care site toolkit, which was developed in partnership with the Army Corps of Engineers, FEMA, USACE, HHS, amongst others. And that's continued to be leaned on as a reference tool out here in the States. And so the ACS concept, whether it's the large convention center model or this non-acute care hotel healthcare model, remains a viable tool for possible resurgence of COVID. So we continue to keep some of these sites warm here as we start to reopen, looking at potential for resurgence. So now I'm going to transition completely into a new topic, testing and contact tracing. I'll quickly move through that. And what I'd like to point out here is that quite possibly the most important tool for boxing in this virus is testing and contact tracing. Contact tracing will be a key component of any successful effort to box in the COVID-19. In contact tracing, local and state health departments quickly identify people infected with COVID-19 using a wide implemented testing program and programs, instruct infected people to isolate, find and notify their contacts, and support these contacts so they can quarantine for the 14 days. In essence, you're boxing in the virus. So testing and contact tracing have been critical tools to control the spread of infectious disease for decades. Contact investigation of patients with COVID-19 potentially exposed at work, and patients in healthcare facilities, congregate living, housing settings with many people is a priority for us here across the states. And as Dossie mentioned, you can add to the list the meat processing plants, because that is another facility that we're seeing outbreaks, large-scale outbreaks here in the Midwest at those meat processing plants. And so we continue now to focus testing onto those at those facilities. So as the state announces various plans to gradually ease social restrictions across the United States, all of them share one critical element, and that's the ability to test widely for infection and then trace the contacts. So that's in order to isolate the people who were exposed and initially and then eventually break the chain of the infection. So contact and testing and contact tracing will continue to be at the forefront of our pandemic fighting efforts. And you'll see that a lot as we move forward over the next few months. So I'll close here. I'll keep this slide up. There's some additional resources I'd like to, Dossie and I'd like to have for you to have. And I'll let you look at those while I give a few remarks, closing remarks. And so again, just to recap, as we reopen and move into the next few months, understanding the transmission reduction measures the vulnerable areas and entities likely to become those hotspots that Mr. Dossi Phelps spoke of, and then seeing those tools that have worked during the response and where the efforts are focused now will only help us with the fight on this pandemic. So we truly do live, to bring this full circle to my coffee mug earlier, we do truly live in a small world, and operation is going to be key to the success of this fight. So I thank you for that. Dossi Phelps with the Global Center for Health Security, and I would like to thank the Crisis Management and Disaster Response Center of Excellence and the organizers of this event, as well as all the participants. We thank you for the opportunity. So with that, I'll open it up to any questions. I'll also go over and list our contact information if you'd like to have that. And then I'll discontinue sharing here.
Thank you very much, gents, for this very comprehensive and informative presentation. There was a lot of information. I wouldn't say that we are overwhelmed by that, but that was great. Thank you very much. Also, I would like to share that we are very glad that, according to you, the situation in the United States is going to the good way. However, what I understood from your presentation, you are still preparing to mitigate eventual infections or spread out of infections, especially to keep transmission reduced. You mentioned that one of the factor could you use it is this CCAR based like on the other countries. But can you tell us how you are going to assure that the information you are getting are reliable, they are valuable, they are not false, they will not make a false picture? Can you ask for that?
Yes, sir. I'm having a very difficult time hearing you on this end. I apologize. I don't know if it's possible to place that question into an email or to another format, and then we'll be sure to answer that question for you and the participants.
Absolutely, no problem. We will send the question to you, and then we will try to public to our followers.
Thank you very much, sir.
Yep. Okay, thank you so much that you are joining us from outside the ocean.